Hi everyone, my name is Jalissa Renteria, and today I will be presenting when VZV goes rogue in an immunocompromised adult. Together, we will walk through the diagnostic challenges, the rapid disease progression, and the key lessons learned in managing this interesting presentation of VCV. So typically in an immunocompetent host, VCV reactivates as a vesicular rash that's confined to one single dermatome. But in cancer patients, oftentimes a reactivation is much more severe, and it can include this disseminated rash that appears erythematous and maculopapular in appearance, but can quickly become vesicular and pustular. So, our patient was a 64-year-old female who had a history of chronic lymphocytic lymphoma and myelodysplastic syndrome. She presented to the emergency department with generalized weakness, shortness of breath, and fatigue. And for the past 10 days, she had experienced night sweats and chills. And on the morning of admission, rectal bleeding was noted. In the past year, she had a diagnosed disseminated nocardia infection, and also she was treated for probable aspergillus nodular pneumonia. Upon physical exam, she was hypotensive, tachycardic, febrile, and tachypnic. She also had moderate adenopathy and neck tenderness, and her laboratory studies did show that she had an infection with increased white blood cell count, lymphocytes, and neutrophils, and decreased hemoglobin and fibrinogen. Her chest x-ray showed new bilateral pleural effusions as well as ground glass density. A skin punch biopsy of her right thigh was performed, and so this immunohistochemical stain showed that there were necrotic keratinocytes, and then the H&E also shows this area of involved epidermidis where there was margination and molding, and these are classic for herpes. But it was really this immunohistochemical stain along with the Carius test that confirmed the diagnosis of disseminated VCV. And as we see here, our patient had these scattered purple central umbilicated lesions that were necrotic in appearance, which is completely different from a typical presentation in the immunocompromised host. So on day 7, she ended up having a confirmed disseminated VCV infection, and so high-dose intravenous acyclovir was started. Unfortunately, she developed shock with profound lactic acidosis, and on day 9, she passed away. Now, although our patient, she didn't have any T cell defects, she was still considered immunocompromised because of her hypogammaglobulinemia, asplenia, and intermittent steroid use for SLE. As far as the differential diagnosis goes, anytime you have a disseminated cutaneous lesion, such as this, the differential diagnosis can include a lot of different etiologies, including bacterial infections, fungal, and viral. But all of our patients' blood cultures and tissue biopsies ruled out these various etiologies. So some of the lessons we can learn is that for patients who have intermediate risk for reactivation, it's really important that the right prophylactic measures are taken in order to prevent a reactivation in the first place. And then in cases where we don't really see this typical VCV feature of this rash, it's really important to do the immunohistochemical stain because that in our patient was what really confirmed the diagnosis before the PCR came back. And then it's really, really important that while we know that VCV can present as that typical erythematous maculopapular rash, it's really important to keep it in our differential, even when we see a different kind of lesion that appears necrotic, purple, and umbilicated. And with that, I really hope that this case underscored the critical importance of our vigilance and adaptability in managing immunocompromised patients where our viral infections can present in unexpected ways and rapidly evolve into life-threatening challenges. Thank you.